Level 2 trauma, room 34.
Left. Chest X-ray for room 34. Line placement.
Okay, doctor. Should this patient go to hospice?
He's just come from the hospice.
Again? Good evening. I'm Left, an X-ray tech and a hospice volunteer from Texas. In this video, I'll talk about the darkness of the emergency room. Recently, I've often seen hospice patients being transported from hospices. My coworker, Alice, also works at the hospice, so she is familiar with how patients move from the hospice to the ER. According to Alice,
at the hospice, the patient's family wishes they could do more. So, they decide to bring the patient to a hospital. Then, the charge nurse tells them that the hospice has to discharge the patient. Then, they go through the discharge process. As soon as discharged, the family brings the patient to the ER. As the patient arrives at the ER, he is treated as trauma because he is likely to die.
It's trauma, so the staff must follow the trauma protocols. An RN sticks an IV catheter to the shriveled vein to take blood samples. The patient is not breathing well, so the doctor inserts an ET tube into the patient's throat. An OG tube is inserted from the mouth into the stomach. A CVC line is inserted through the jugular vein to the heart. Lastly, an X-ray tech takes a chest X-ray with a portable machine. After a while, when the patient calms down, he is transferred to the ICU. Alice continues.
Even if the patient is admitted to the hospital, he will be discharged soon. And then he will return to the hospice. They just repeat again and again.
Alice told me about another episode. As soon as the hospice physician pronounces death, his family changes his attitude. They call 911 to get the body to the ER. The family is compelled to do something for the loved one. That same night, a second hospice patient was brought in. The patient was a 78-year-old petite Caucasian woman who was unconscious. The staff was giving her CPR in the room. The patient's husband took a smartphone and walked up and down the corridor. He was trying to get in touch with his wife's physician. As soon as the wife's doctor answered, the phone was given to the ER doctor so that they could communicate with each other. You probably have never seen an elderly person receiving CPR. You need to compress the middle of the breastbone at a rate of 100 to 120 times per minute. You must push 2 inches deep and recoil to its original position. It looks as if you were dribbling a basketball. I always think that most older women have osteoporosis. Therefore, you could easily break her ribs, pushing her chest so hard. This chest compression lasted about an hour. Once the pulse returned, the ET tube would be inserted, and other lines so that they could give meds to the patient. Unfortunately, the patient didn't come back. After a while, I talked to the ER staff, who told me that this patient had colon cancer. The ER staff who did CPR said that she heard the ribs pop at the first push. Although you hear ribs crack, you are not supposed to stop the chest compression. What did he expect when he sent his wife to the ER? Hospice does very little for patients. So, does her family bring her to ER because they want to do something? I ran into Brenda, a nurse practitioner who works the same shift, so I asked her about it. According to Brenda, it's common for families who haven't experienced the death of a family member. They cancel all palliative care agreements, such as DNR and hospice services, and change the status to full code. Brenda said,
If the patient's life got sustained, you need to go through with the family about DNR and palliative care service and get their consent. Again and again. Such a patient should not come to the ER.
She replied in a weary voice. Some people think the best death is in a hospital, giving CPR while the family is grieving and crying. I have worked at this hospital for 16 years and have seen various patients. When you come to a hospital, our mission is to save the lives of our patients. However, all people are destined to die someday, so they leave and pass away despite the excellent nursing care. Sometimes that kind of care is inappropriate for the patient's condition and may hasten death. That's primarily chest compression of CPR. CPR is effective for children, young people, and patients whose bones are still flexible and whose condition has a prognosis for recovery. It is because the true purpose of chest compression is not to restart the heart, but to push the heart to send blood to the brain and prevent brain death until the pulse returns. Since hospice patients never fully recover, this continues until they die. CPR happens in the ICU as well. I sometimes see the patient's family crying outside the room. Why did the family want the full code? They don't know what to do. They don't want to do a wrong thing. Therefore, they incline to the hospital protocol. Full code is a patient's or family's request to resuscitate if the heart stops. If there is no request, patients will automatically be full coded. On the other hand, there is DNR. DNR means do not resuscitate, or AND, allow natural death. The choice of DNR may sound like giving up hope. Therefore, it's difficult for the patient's family to accept. I understand that the family never wants to let the patient go. But I hope the family will accept the death of their loved one and give them a genuinely loving and memorable farewell. Please pass on the message of my video to your family, relatives and friends. How did you like this video? Thank you for your viewing. Let me know what you think about this video in the comments. If you like this video, please give me a thumbs up. I will continue to deliver videos about the darkness of the hospital, so if you are interested, please subscribe to the channel.